Thank you very much for that kind invitation. And I didn't change the title slide because most of this, some of this work actually was done here at UCSD, and a lot of it was done at the University of Vermont. So I thought I'd start with a case report, which is always seems to give a talk a little bit of relevance. And this was right here at UCSD back in, I would say, 1988. 26-year-old male is a Navy hard hat diver, and I don't know if you saw that movie with Robert De Niro, and the guy loses his leg. And you have to understand that hard hat divers in the Navy, salvage divers, they are first rate. They're like the special forces. A lot of training goes in. The Navy tries to retain them. If they get out of the Navy, they get six-figure jobs. Father of two, is involved in a motorcycle crash, dislocated hip, a T4-C6 fracture, and a paraplegia, which is incomplete. On hospital day one, we give him Venadines, no heparin, obviously, because of his spinal cord injury, and he's improving. But on day three, deteriorates, and Larry Marshall does a laminectomy on him. He improves. By day 16, he's moving both lower extremities. Now he can feel his legs. He's complaining of knee pain. We didn't get an MR. I think we got a CT or a clinical diagnosis because we didn't have MR in those days. Had an ACL injury. He's put in a posterior immobilizer, and we feel it's safe now to start heparin sub-Q. We didn't have low molecular weight heparin in those days either. By the 29th postoperative day, he's using both of his extremities, and Sharon, you may even remember this patient, and he's ready to go to Sharp, to the rehab. And we have his daughter, his two kids, and his wife downstairs going to pick him up. They're down in the lobby. They got the balloons, everything, you know. We go in to see him, and he's dead. Dead, absolutely dead. And his post shows, basically an obstructing pulmonary embolism. So that sort of galvanized my interest. Then I started talking to Ken Mosier, who, rest in peace, a great pulmonologist here, had a long-term interest in venous thromboembolism. It got me thinking about it. So I thought we'd talk a little bit about the incidence, the pathophysiology, the diagnosis, the management, the prophylaxis, and the treatment. What is deep venous thrombosis? And whenever you talk about it, there's a little bit of a caveat because people think that deep venous thrombosis includes only the popliteal and proximally, but actually it's any deep vein, which includes the leg veins, and in fact, if you really were going to get critical about it, the soleal plexus and the calf. We're more interested, however, in calf vein propagation because about 20 to 25% of calf veins, that would be the perineal, the anterior tibial, the posterior tibial, those will propagate into the larger vein, the popliteal, about 1 out of 4. So if you have somebody with calf vein deep venous thrombosis, it is in fact counted as deep venous thrombosis. The soleal veins, however, we don't worry about too much because only about 3 in 100 will propagate. So I think basically if you had a factor V Leiden or anything else, you probably would need to repeat the ultrasound or do anything much about that. Just tell them to ambulate and so on. Now, proximal DVT is where we get a little bit worried because thrombosis in the popliteal vein or the proximal popliteal vein, if it is untreated, will embolize. And there's good data about this. About 1 in 5 will embolize. Okay? So that's where we really get concerned, and that's where we really get aggressive about treatment. Now, there's some more caveats about the incidence. First of all, it's how hard you search. So there's a surveillance bias involved in detecting of venous thromboembolism. The harder you look, the more you're going to find it. And the better your ultrasound technologists are, the better you're going to be. It's the same with autopsy studies. When Sevitt and Gallagher did the original studies on burn patients back in the early 60s, they found a very, very high incidence in burn patients. Subsequent burn studies have not shown it. But again, it's how vigorously you search. And even, myself, when I've gone down to postmortems, I have to tell them to go down and cut the leg veins. Let's go look. As you also know, venous thromboembolism is pathognomically signed. There is no sign that you can say unequivocally, this clinical finding, we will find a DVT. It's not the swollen leg. It's not a positive Holman sign. Holman sign is more it has absolutely no specificity. A swollen leg, we see swollen leg all the time in trauma patients, and rarely, often they'll have a deep venous thrombosis, but many times they won't. Give you an idea of how often it's not clinically suspected. Gertz's study, 1994, New England Journal of Medicine, they did venograms on all of their trauma patients, okay? And only 2% of the patients that had popped positive for a venogram had a clinical suspicion that they had a deep venous thrombosis. And the interesting thing, Sandler's study in the archives in 1989, and this is 10% of fatal PEs, only 10% were suspected. The other 90% were not suspected. It was a surprise. Clearly, retrospective studies underreport because we don't necessarily often write that. So what is the clinical incidence? This is a patient I took care of in the Navy. You can tell this is before we did a lot of, this is when I was a house officer, but this is Neufeld's traction in case you don't recognize it. This is an old MA1 ventilator. But anyway, the idea is that the incidence is surprisingly high. And this is from Geertz's study. This DVT includes calf vein, 58%, 18% proximal. And interestingly enough, as you can see in his study, well documented, approximately 1 in 5 embolized. This was without treatment. With treatment, and this is from George Velmahos's work, and this is really a sort of a consortium report, found in patients with prophylaxis, there's a 1.5% incidence of pulmonary embolism, and about 12% of patients will have a deep venous thrombosis. Now, George is very interested in this problem. In fact, I'm going to bring up Dr. Coimbra's comment on his article, which appeared in the archives about 2 or 3 months ago. Now, with prophylaxis, this is data from UCSD, and we were pretty aggressive in those days about surveilling, but we used to use PPGs, which is, you'll find that in the medical museum. Don't use them very often anymore. And Peggy Knudsen in '92 with more aggressive use of ultrasound, a 12% incidence with prophylaxis. The takeaway here, it's still common, even with prophylaxis. And this thing we'll have to discuss, and hopefully we'll get some good discussion from Raul about this, is prophylaxis effective or not? And we'll discuss that a little bit. Well, in the NTDB, which is the National Trauma Data Bank, an unvalidated database to which we all submit data, Peggy presented this to the American Surgical. She asked me to discuss it. And I got the manuscript ahead of time. This was on 450,000 patients that existed in the database from 1994 to 2001. An incidence of 0.22% of DVT and an incidence of PE of 0.11%. You have to say to yourself, wait a minute, hold it. That's not what those of us in the trenches are seeing. What's wrong with this picture? Well, first of all, Peggy did not identify a high-risk cohort, and we'll talk about that in a little bit. Not every patient that comes to the trauma service that's admitted to our trauma service has the same degree of risk. Some are more high risk than others. Secondly, there was no data in the NTDB on prophylaxis at the time that she pulled all this data out. So if I make the assumption that all patients were receiving prophylaxis, and I assume that prophylaxis decreases pulmonary embolism by 67%, then these 522 should have really had 750 DVTs, if in fact they are doing what they say they are doing, and if in fact, and this was the question posed by Velmahos, are the two really causally related? Does PE come from DVT? And I'm assuming it does, and I think Raul feels the same way about that. So the conclusion is, all I could draw from Peggy's paper was that surveillance in the NTDB is poor. It's really poor. And as I told you, it's surveillance bias. The more aggressive you are about looking, the more you're going to find. If you're not aggressive, you're not going to find it. And that's what's wrong with the SCIP issue, the Surgical Care Improvement Project. If you don't look, you're not going to find it. You can report a very low incidence of VTE in your patients. So the summary is venous thromboembolism is clearly underreported. It remains a common clinical problem. And patients at risk should receive prophylaxis. That's the guideline right now. Now, how do we figure out what the risk is? Well, to do that, we need to understand the pathophysiology. And I think everybody in this room knows about Virchow in Vienna, right? And he basically said that there are 3 interrelated causes: injury to the vein, hypercoagulability, and stasis. And the relationship to each of these to risk has not been quantified. Is it a linear relationship? In other words, if you have injury and hypercoagulability, does that double your risk? Or does it square your risk? We don't know if it's a geometric or a linear relationship. Now, it's interesting, isn't it? Because all of these exist at the time a trauma patient is admitted. Okay? They come in, they've been injured, right? They wouldn't be here if they weren't injured, right? We all think trauma is a thrombophilic state. It makes teleologic sense, right? Okay? And finally, they're laying on a gurney, right? So they got all 3 things. And if those of you who were around, and I was a house officer when the data on subcutaneous heparin came out, that's supposed to be given preoperatively. It should be given before there's venous injury. So then you have to ask yourself, is prophylaxis with heparin superfluous in the trauma patient? And that's a question I can toss out, and perhaps we can discuss it. Remember that all your patients that are bedridden lose the calf muscle pump, and that's probably the most important thing in preventing stasis is your calf muscle pump. Again, if you're over the age of 40, you have an increase in the number of soleal sinuses in your calf, and that's probably the effect of standing for long periods of time, probably higher in surgeons. And then paralysis. Remember, we paralyze our patients a lot. We paralyze them to operate on them. We paralyze them sometimes to control their ICP. So that also is contributing. So there's a real situation here where trauma patients are at risk. Now, what about injury? Well, obviously local endothelial injury, those of you who operate on blood vessels know all about this, right? It's that white clot we see sometimes because we've injured the endothelium. Local endothelial, there are changes in the endothelial cell phenotype, as you know. At any given time during the month, you are a little hypercoagulable on the surface of your endothelial cell. Other times of the month, you're not. You're like thrombolytic. You can't form clot. Those who did the early studies with iodine-labeled fibrinogen, they would scan patients just sitting there, and they could watch patient over a period of an hour turn from negative to positive, just in the sitting position. So you're forming clot all the time. But if you have injury, you have exposure to the subendothelial matrix, you get platelet activation, and you get local thrombus formation. That makes sense. Now, can local endothelial injury cause systemic effects? Can trauma cause systemic effects? And this is where this paper that Dr. Coimberg discussed in the archives, and Velmahos, I think he needed a platform to bring this theory forward. He believes, or he posits in this paper, that in fact clot is forming de novo in the pulmonary circulation. Okay, so is that pretty far-fetched? Well, Raoul points out that their hypothesis, or what he's saying here, cannot be proved by the data in this paper. They're totally almost unrelated. But I think, as he points out, perhaps the answer is in the basic science laboratory if one can demonstrate differences in clot formation, endothelial response in extremity veins, and in the pulmonary circulation. Now, there is a little bit of remote data. Back in the 70s, this was proposed that, in fact, remote injury can change the endothelial phenotype, perhaps, at remote places. And what was studied here, and it's a very simple experiment, they looked at canine jugular veins in dogs that one group underwent splenectomy, another underwent hysterectomy, and another underwent intestinal anastomoses. And what they did was then they scanned the jugular veins, and this is what a normal jugular vein looks like. There are a little bit of platelet aggregates there, but pretty much it's a fairly smooth endothelial surface. Now, if you give the dog a splenectomy and then you rescan, you can see that there is, and again, this is remote from the jugular vein, this is what you see. You begin to see some clot formation. And then if you add up the trauma and make it even more severe, like the intestinal anastomosis, you disrupt the bowel, then sew the bowel back together again, you see even more clots. Okay? So why does that happen remotely? Well, Mark Meissner and Owings up in Davis have done a lot of work on this. And basically what I want to leave you with is that by and large, trauma and any subsequent inflammation is a thrombophilic state. So the point is that trauma patients are pretty much, especially trauma patients with a moderate amount of injury, are at very, very high risk for this problem. So, injury, the summary. It has local and remote effects. The local effects are due to direct trauma. The systemic effects may change the endothelial phenotype and, in addition, create a thrombophilic state by all the changes in the coagulation factors. Now, how do we make the diagnosis? I had mentioned this earlier before. It's dangerous, it's way too sensitive, and is no longer used. Venography is impractical in trauma patients, and plus the fact that when you inject dye into the vein, you can induce thrombophlebitis and create a clot, so that's not a good idea. So duplex is ideal. The accuracy is reasonable. The criteria are, and if you ever watch this done, you can see the technologist will take the transducer and compress the vein all the way down. And those of you who are ultrasound competent can do this yourself. Not a very difficult examination to do. Just learning how to orient the transducer and get it, look at the screen and orient it correctly. You can also visualize thrombus and non-occlusive thrombus. Generally, the protocols pretty much vary. We try to do it over at Mercy weekly. We did it at University of Vermont. But remember, it is really technologically intense. It's going to consume a technologist for 60 minutes, and that makes it wreaks havoc if you have a vascular laboratory. The limitations are, again, the logistics of getting the tech down to get the scans all done. And then there are certain lesions, for example, large wounds. You can't scan over them, or plaster immobilizers, or external fixators. In the paper we produced here, 1/3 of our patients really couldn't be scanned reliably. So it does lose its efficacy as using it as a screening. The diagnosis of PE right now, we're out of this pulmonary angiography business anymore, and it's really high-resolution CT is the ticket. The thing I worry about, of course, is that it's getting so good, you're going to be picking these things up, these tiny, tiny clot, and then you're going to say, what are we going to do? This guy's got a head injury. So I don't know what that's doing. It's certainly heightening the sensitivity for this diagnosis. Now, the treatment is low molecular weight heparin. It's weight-based. You overlap therapy with Coumadin. You start, with the heparinoids first. And the reason is that Coumadin has its greatest effect early on in protein C and protein S. So you don't want to make them more hypercoagulable. So you want to get the heparin to start with, then you start the Coumadin. And if you have a contraindication to anticoagulation, you use caval interruption. This is data from the Vena Cava Consensus Conference, Journal of Vascular Surgery in '99, and then the East Ad Hoc Committee on Practice Guidelines, which was actually chaired by a colleague of mine, Fred Rogers. And basically, what the traditional recommendations are for a caval filter, and this is pretty much always, those of you who are surgical residents or fellows will get this on your oral boards pretty much. They'll get you to this point where you've got a contraindication or a complication of heparin. What do you do? So DVT with contraindication of anticoagulation, an absolute nobody would argue with, but there are relative ones which bring your judgment into play. They'll push you hard on that. Then there's a complication of anticoagulation. Now that's failure. So you have DVT propagation in someone who's adequately anticoagulated. That means that you should think about a filter and put one in. If there's major hemorrhage, if there's thrombocytopenia from HIT, and if there's skin necrosis from the heparin injections. Now, these are what we used to use for caval interruption. This was the last DeWeese clip ever used at University of California, San Diego. Dave Hoyt and I put this on a patient of ours. This is a clip that goes around the inferior vena cava. You mobilize the cava, slide it around, slam it down. And the idea, this is from James DeWeese at Rochester, the idea is that through these channels the blood will continue to flow. Right. I think by the time we had the patient closed, his cava was clotted. So we've obviously gotten away from that. That's the Mobin-Uden umbrella. And those pretty much had a higher rate of caval occlusion as well. They were basically a functional occlusion of the cava, like the DeWeese clip. You should also know that people used to go in and ligate the cava. Put an umbilical tape around the cava and ligate it, and then the first thing they heard was the anesthesiologist screaming because the patient had no blood pressure. You just can't shut off the return from the lower body like that so acutely. Now we use the Greenfield filter. In this case, this is a Gunther tulip filter. It traps emboli as long as they're greater than 3 millimeters. It results in a 97% patency, both laser Greenfield and at the University of Vermont we looked at, and that's about right. There is a 3% recurrence of pulmonary emboli, however, and not really sure why that happens. The complications are insertion now, since these are put in. Vascular surgeons used to put them in, but now they're being placed percutaneously, and I think probably what happens once they go through the vein, they mash down for it for a while. The IR fellows holding the vein, and I think they get a DVT from that. We've seen a number of perforations. In fact, I was called to the ICU, and there was a patient they were nervous about in the MICU because one of the struts was in the duodenum. It was out through the cava and into the duodenum, but the patient had a completely benign abdomen, and they had gotten a CT scan for some reason. I don't know what it was, and they asked me what we should do about it. I said, destroy the CT scan. I'd get rid of that. Also know if there's a tilt, if there's any kind of tilt, then it becomes ineffective. So you really have to sit them so that the cone is right in the center of the cava. Now, what about prophylaxis? Low molecular weight heparin, 30 to 40 subcutaneous QD or 30 milligrams Q12. And then compared to heparin, it appears to be more effective, and I will show you that in a second. And the bleeding, the complications of heparinoids, obviously bleeding. HIT occurs with both low molecular weight heparin and heparin. This is from Gertz's study in the New England Journal again. This is low-dose heparin here for prophylaxis, and you can see that even, this is all DVT, including the caffeine. There was still 49% incidence. Proximal DVT was reduced, bleeding in only 1, but low molecular weight heparin appeared to be more effective. But I think the take-home here is it doesn't bring it to zero. Doesn't bring it to zero. Now, I put this in because I've always been bothered by all these process things that go on all around us without a whole lot of clinician input. And this happened to be the SCIP. Now, SCIP is a surgical care improvement project, and they are rebating hospitals if two things happen. One, you document that you've assessed the DVT risk in your patient. And two, if you start them on some form of prophylaxis, and if there's a contraindication of pharmacologic prophylaxis, you document that. Well, because Fred Rogers had been interested in this for a long time, we had always pushed it at M&M. You know, if a patient died of a PE, we would just, you know, really harp on how important prophylaxis was. So we went back and we had this process that Dave Hoyt and I had actually started here at UCSD, and that was filling out a complication form on every patient. I took it with me back to Vermont, and we really track every single admission to surgical service. And now we have there's a whole little tiny sub-department within surgery that tracks every patient. And we had good data on 37,000 patients admitted to the surgical service there. And we had the highest, this paper has the highest partial or complete compliance with ACCB guidelines. It's the American College of Chest Physicians guidelines, which SCIP advocates for. Risk assessment and actually applying them. We had 6 deaths during that time of 10 years on the surgical service. 4 were from PE. Because this includes all of the patients, right? Okay. And here, right about here is when we got really serious about educating our staff about venous thromboembolism. And you can see between 98 and 99, the incidence went up. Nothing changed. We just started looking for it more. Okay, that's classic surveillance bias. You can see the highest is on the trauma service. But I think more importantly, if you look here, and this speaks to what Velmajos is talking about, if you look at PE and DVT or both, these are PEs, these are both, and these are DVTs by themselves. So these you'd think we'd have more both, wouldn't you? I just don't know how that happens. Are we missing them? Are they breaking off and going to the lungs, and now they have a normal study? I don't know. We also looked at what was called morbidity burden, and this is something that I'm fixated on. I can't get it out of my head. Not every complication carries the same amount of morbidity to the patient. Okay, so if you get calf vein thrombosis, that's one thing, and that's clearly a problem. But if you have an iliac vein thrombosis, that's a whole lot more morbidity. And as a vascular surgeon, I can't tell you how many patients I would see in our venous ulcer clinic that had a remote history of trauma. It was incredible. And these patients now are incapacitated from their venous stasis ulcers 15 years after the fact. So we developed a scale, and this is an arbitrary unit scale of morbidity burden, despite the fact that we were compliant 84% with the SCIP guidelines. You know, look at this. Look at that morbidity burden. It's going up. It's not going down. It's going up. So I'm not sure that we're on the right track yet with pathophysiology and prophylaxis. Now, you all know about squeezers, right? And again, the problems that they have, and again, about 35% of trauma patients are unsuitable to get both legs with squeezers. Foot pumps, no data yet on foot pumps. I mean, the orthopods like them. They think it's a little bit better, and it makes sense that, you ought to use them, because there's clearly, when you measure velocity of flow, the velocity of flow goes up when you squeeze the foot. But I don't know how effective they are. This study, the one I just showed you, that was in surgery, That's an efficacy study. How well do these things work in the real world? So we thought we were really doing well with 84% compliance, but I don't think we affected. In fact, the rate of VTE went up in our patients. So now, again, I bring up, so now what do you have? You want to give prophylaxis to this guy, okay? He's got bilateral closed femurs. He had an open tib fib. He's got a splenic repair. He's had a liver resection, and he's got a closed head injury. How do you prophylax this guy, okay? So that's where we get the extended indications for using a filter. And these are what both of these conferences came up with. Free-floating thrombus, looks like a piece of seaweed in the iliac vein. Massive PE with minimal residual lung. And actually, when I was here, Pat Daly and I used to do the pulmonary thrombectomies. You know, he would take these patients. We had a number of patients that over the years had chronic low-grade pulmonary emboli, and now they only had one lobe functioning. You know, he had obstruction to all the other lobes, so it's really interesting. Anyway, following surgical embolectomy and then the high-risk patient, increased age or history of DVT, brain or spinal cord injury, complex pelvic fracture, multiple long bone fractures, this would be placing a prophylactic filter. The idea being you're not going to prevent the DVT, you're going to accept that, but you're trying to prevent a pulmonary embolism. Now, why are trauma patients so special? I think all trauma patients with significant, I'm not talking about the lady who falls on Coumadin and comes in with a bruised elbow and 2 negative head CTs. I'm not talking about her. I'm talking about the young kid who comes in with a pelvic fracture and a femur, okay, maybe a broken back, and he's going to be in bed for a long time. This is the high-risk patient. And we see, again, going back to that Navy hard hat diver, we see this as a common cause of death. Many of our patients have a contraindication to anticoagulation, and they can't get compression hose, and we can't do surveillance on them. And interestingly enough, as Ken Mosier reminded me repeatedly, the susceptibility extends through the rehab phase, because he was seeing a lot of patients with PE that were over at Sharp coming back here to see him, and they were no contact with the trauma service at that point. And as I said, keep harping on, medical prophylaxis does not seem to be completely effective. So trauma patients are special. Now, what about the prevention of pulmonary emboli with these filters? And this is from Bill Fullen and his colleagues at the University of Cincinnati. Again, an old study, but it's a good study. It's really a good study. He looked at 100 consecutive patients with hip fractures, prospectively randomized. 41 went to prophylactic IVC filters, and at that time they were just a little nervous about giving trauma patients prophylaxis, so 50 had no prophylaxis. Okay, so that's, you'd say, well, that's a flaw in the study. And they were well matched for age, comorbidities, fracture type. And again, I encourage you, this is one of the classics in trauma, I think. So look at this data. The IVC group had 1 PE, and that patient died of a PE. And the control group had 14 deaths with 8 PEs. So it looked to be pretty effective, that filter. And those were mobenudins too, by the way. So the results indicate that prophylactic IVC filtering is safe and effective method to reduce. Now, I think they were Greenfield filters, actually. Both pulmonary emboli and mortality in a series of high-risk patients with fractured hips. So a lot of people have really, you know, gotten on this, we don't need the filter and so on. But I think there are cases where you're going to be, you know, thinking about doing it. I had a guy just the other night, came up quadriplegic, 49, 50-year-old guy, ejected from a motor vehicle accident. He got his filter that night. That's how serious I mean, there's been data, too, that's shown that if you take a paraplegic or a quadriplegic, by 28 days they all have a DVT. Even with prophylaxis, because there's no movement down there, moving stuff up. So, again, I think these are kind of unresolved issues. There's a lot of debate about it, and I think it's highly biased myself, and I'm biased for it, and I'm part of it. Now, these retrievable filters, this is an interesting thing, because they put in these retrievable filters and they'll move them around and everything else, but actually a very small number of them actually get removed. This is our data, our initial use with them. Chris Morris is a great guy, and Ken and Jerry, and they were our IR guys at Vermont. And in 15 months, we put in 55 filters. And they charge every time they reposition them, because they recommend every 15 days you change the position on them. but we did not remove 22. Okay, we probably removed about 15. So I would say that these are rarely retrievable. And the group at shoot, I've forgotten now, looked at this, and they aren't, because what happens is they get lost to follow-up and nobody pulls them out. So for all intents and purposes, the retrievable filter has now become only rarely retrievable. So what about a practice guideline? So here, this is what I would suggest is pretty much acceptable to everybody, what I'm going to talk about. I think, again, you must consider the risk of all your patients. And I don't know how to weight each of these factors. As I said before, there does not appear to be a linear relationship between injury and endothelin. It looks to me like it really becomes a quadratic. It's a geometric relationship. The more risk factors you have, the greater and greater is your risk. And I've also thought that if you have a septic complication, your risk absolutely is off the board. So a guy comes in with a busted pelvis and a femur, and you say, okay, he's in the moderately high group, squeezers and pharmacologic. He gets a urinary tract infection or he's got pneumonia, the risk is now much, much higher, much higher. And just look for yourself, because we did this work, and I can tell you it does change the risk factors. So this is from Peggy's Annals of Surgery article. So if you have a low odds ratio for VTE, and again, I wouldn't use hers, I'd do your own for your own hospital. But if heparin's okay, then, and this is odds ratio for venous thromboembolism, low molecular weight heparin would be the way to go. Okay? I think all patients should have some pharmacologic form of prophylaxis when they're on the trauma service, unless they have a real significant reason not to use it. Higher odds ratio, if you can't use heparin, vena cava filter. If you can, low molecular weight heparin and pneumatic compression boots. And then very high heparin, okay, no. PC being practical, then you put in the filter. And I think those are all reasonable. So in summary, it's a clinical problem of some significance. It is common. It's underreported. It's a common cause of death. When we looked at all 620 deaths in San Diego County in 1987 or 88, we looked at, I had postmortems on every single patient that died of trauma. This was the second, after multiple organ failure, was the second most common cause of death in hospital, was pulmonary embolism. And again, there doesn't appear to be effective prophylaxis, and I wonder if there isn't a thrombophilic resistance here to heparin. And that's Burlington, Vermont, where Fred's brother was a surgical resident. And I'd be happy to answer any questions. Thank you for your attention.